Hello, and welcome to this episode of Impact Education's PayerTalkCE podcast. The title of today's podcast is Advancing Equity Pediatric Atopic Dermatitis Management in Managed Care. I'm Gary Owens, and I'll be the host of this call. I'm a family physician by background and also spent about 30 years in payer world. I'm pleased to be joined today by Dr. Joy Wan. Dr. Wan is Assistant Professor of Dermatology at the Johns Hopkins University School of Medicine. Welcome, Dr. Wan.
Thank you so much, Dr. Owens. It's great to be here and to be able to chat with you again about this very important topic.
Great. Well, it's good to see you as well. And yes, we did have a previous call, so thank you for taking time out today. Before we get started, I do want to let our audience know that this PayerTalkCE program is jointly provided by the National Eczema Association, Partners for Advancing Clinical Education, and Impact Education. It is designed for a half hour of continuing education credit. Also, this activity is supported by an independent educational grant from Sanofi and Regeneron Pharmaceuticals, and we'd certainly like to thank them for their support. Well, Dr. Wan, let's start it off. We met just about a year ago, how time flies, and we talked on PayerTalkCE about the journey of the pediatric atopic dermatitis patient. And it's a pleasure to revisit that conversation. The last time we chatted, you described a typical journey for pediatric atopic dermatitis patients, although I'm sure many of these patients are unique and far from typical. For the benefit of our listeners, could you share a brief overview of that journey? Specifically, I'd be curious to know a little bit more about what it's like for these patients and their caregivers if they have moderate to severe atopic dermatitis.
So that's a great question to kind of start us off, Dr. Owens. And as you mentioned, not every single patient or family has the same experience. There's so many different lived experiences with respect to kind of the atopic dermatitis journey and their care. So I might just highlight some of the broad strokes in terms of kind of that path for a lot of patients. So I would say that most patients, especially pediatric patients, are going to first see a primary care provider for their atopic dermatitis. Part of it is that children, often have at least annual well visits, if not even more frequently when they're younger. And so when atopic dermatitis presents pretty typically, I would say that most pediatric providers can make a pretty accurate diagnosis and often start with some first-line treatments, often in the way of topical therapies. But, as you were saying, Dr. Owens, those with more moderate or severe atopic dermatitis, they may not respond, right, to some of these first-line topical therapies. And so some primary care providers may opt to refer them for specialty care to, say, dermatology, or some families may even request it sort of out of their own accord. And so I will say that in my own clinical practice, right, a lot of my patients need a referral to see a specialist, such as myself. And so once that referral gets placed, I would say most primary care providers are happy to place the referral. They place it, but then what I, have often witnessed is that access to dermatology can be really challenging. And so patients are waiting, often sometimes, months, maybe even several months to come in and be able to see, say, a pediatric dermatologist. So that's sort of one element that kind of really stands out in that journey. And then once the patients come to see a pediatric dermatologist, I would say that most of them have had atopic dermatitis for quite some time. So if I'm seeing an infant, it's often been at least, a few to maybe several months. For older children, it may have been years. They've had eczema since they were a toddler, right? And now they're, in their kind of preteen years, for example. So while, the severity can certainly vary, what I would say is that oftentimes we tend to see more of these kids who have very chronic atopic dermatitis or much more moderate to severe kind of severity levels of disease. And then I think the other element that really stands out to me as sort of a specialist is that, and again, there's probably some referral bias here, but a lot of times by the time that patients and their caregivers make it to my pediatric dermatology clinic, they're often quite frustrated and just distressed by their skin disease by the time they see me, which is not unsurprising. They're very stressed about the lack of response to prior therapies or just the chronicity of the disease. And we also know that atopic dermatitis affects a lot of other things like sleep and, social function, stigma, bullying, right? Anxiety or depression sometimes for kids and their families and caregivers as well. So that's what I would say is sort of kind of more of a broad strokes, perhaps a common sort of journey for patients before they come and see me.
Well, thank you for sharing that, Dr. Wan. And wow, you were almost reading my mind because I was thinking For those children, I was in primary care practice, and you're right, I did see a number of patients with atopic dermatitis. Fortunately for me, most of them were mild to moderate disease and not difficult to control. And I was in practice a bit ago before I went into the payer world, and those delays getting in to see a dermatologist weren't necessarily as long as they are now. And so why I said you were reading my mind is I can sense that these patients and their parents may have a good bit of frustration for, number one, having had a good bit of treatment that didn't exactly get the results they wanted, and then finding out that, wow, I have to wait another month, 2 months, or even longer, 3 months or more to see a dermatologist, or even longer for perhaps a pediatric dermatologist like your practice is. And that's, you're in an urban area, I'm in an urban area. I can only imagine that frustration and those delays sometimes get magnified in areas that are underserved or perhaps more rural and have fewer specialties. So you raise a good point. These patients, by the time they get to you, can be more severe and in many cases frustrated with the whole process.
Absolutely. Yeah.
So tell me a little bit, now that you're seeing these patients, and notwithstanding they may have had their disease a long time and you're seeing perhaps some of the worst of the worst. Tell me a little bit how you approach treatment and how you use evidence-based approaches to the treatment of your pediatric patients, these more moderate to severe patients.
Yeah. So, I mean, first off, there are certainly published guidelines, right, that have been issued by our professional societies. So these societies include the American Academy of Dermatology, the American College of Allergy, and even ones beyond those societies. But, there's certainly kind of these written guidelines. But what I will say about atopic dermatitis treatment is that treatments really have to be tailored to the individual patient and their family, right? And I often will tell trainees and even patients, that I see, that atopic dermatitis treatment is just as much sort of art as it is science. And I think that, one of the reasons for this is that there's multiple therapies that are out there for atopic dermatitis, some on label, some off label. But then we also have a growing number of treatments, both topical and systemic therapies for atopic dermatitis. And so it's no surprise that, when you have so many different and also a growing number of therapies now available for this condition, we need to be able to kind of select, right, the most appropriate and most likely to be the most effective, right, treatment for any given individual. And I think, related to this, there's some considerations that we really have to take into account in our pediatric aged patients. And so one of the things that I certainly think a lot about when I think about treatment selection for a child are things like safety and efficacy, especially in the long term, right? Because, we certainly can cite, clinical trial data that show that treatments are efficacious. But, when we think about putting a child, say, on a therapy for potentially years, right? Or even well into their adult years, what does that really mean, right? From, an effectiveness standpoint, and then also from a safety standpoint, which, oftentimes in trials, those are much shorter term. And, I think some of the long-term side effects of potential treatments are not very well characterized at this point in our areas that continue to evolve as we learn more. So that's sort of, one thing that you have to really pay particular attention to in children. The other thing is also kind of adherence, I think, that oftentimes, we have to think about as it relates to young patients. Some treatments for atopic dermatitis come as, certainly some are topical therapies, but some of the systemic therapies or are injectable versus oral, or if we're talking about phototherapy, right, it's a light booth. So there's different modalities, children of different ages and of just different, they're going to have different preferences, right, for these types of treatments. And also, monitoring, right, lab work, right, which may not seem as onerous to perhaps you or me, but to, a 6-year-old, right, it can really, become a major factor sort of, and whether they want to, or are motivated enough to kind of go through routine labs, right, periodically to stay on, say a treatment that needs that monitoring. And so those are things that are, I think, very specific to pediatric populations that I have to kind of think about when I select any individual treatment or treatments for a patient. And then I think, the other sort of thing, which I alluded to earlier, is that atopic dermatitis doesn't just affect the skin. It often coexists with a lot of sleep disruption, a lot of mental health and social impairments. And so these are other kind of outcomes that you really have to kind of consider when you select treatments, and also when you evaluate whether a treatment is effective or not. Because even if a child has objectively kind of more mild to moderate atopic dermatitis, but they cannot sleep at night, right, and thus as a result can't function day to day, say in school or whatnot, then that suggests to me that they may need something much stronger, or sort of escalated in terms of kind of the treatment regimen to be able to adequately treat kind of all the extracutaneous symptoms that may arise with the condition. So those, I would say, are kind of the things that I think about when I'm selecting treatments. And so, I think to sum it all up, like, there really has to be a two-way discussion with patients and their families. I think, the concept of kind of shared decision-making is really vital in this setting, and caring for pediatric patients, and then also in caring for, a very chronic disease that can be quite debilitating and have, severe impacts on quality of life.
And again, thank you for that. And certainly I understand the complexities of managing these children with atopic dermatitis. As you point out, there's still a good amount of art in handling these patients, and not everything can be just literally by the books. I think I was also taken by the fact that you do have to consider that long-term therapy, maybe years or decades of these children's lives, and the impact on that. My old professor of pediatrics used to remind us that kids are just not small adults. They have unique circumstances, just like you mentioned. Getting an injection every week or 2 weeks or every month, not a big deal for an adult, but can be an issue for a child. Or getting lab work every month or so, a big issue for a child. And as a payer, it certainly brings home that sometimes those policies and maybe the formularies and other decisions that we have to use on a population basis that are, I'll be honest, often built with adult populations as the center of focus may not always allow for some of those unique circumstances of kids. And I think we as payers, need to be aware of that and take into consideration some of the things that you mentioned, and also those patient preferences, parent preferences that inform decision-making that you talk about comes into practice. So I think we all have to be aware, again, that children may not always fit into the same mold as the policies and guidelines that we use on adults.
Oh, absolutely. And I think, just to also expand upon that, a little bit, like when we talk about kind of these different treatments that require different, routes of administration and such, right? Like, we have injectable treatments, for example, for atopic dermatitis, and they're approved for kids who are very young. But I have taken care of multiple families for whom it's just not feasible for a caregiver to give an injection to their, 4-year-old or 5-year-old at home because, it's not safe, right? The child kind of fights it. Parent really, doesn't feel comfortable doing that. And it's really, I've been told, just traumatic for both the child and the family. Like, that's literally how, a lot of my patients have described kind of that experience. And so then when you start thinking about, well, what about other types of treatments, right? And kind of jumping through the hoops to get them access to those, sometimes we're limited, with respect to age indications and things like that. And so I think we also have to think about potential kind of services, ancillary services beyond just kind of treatments themselves when we think about treating atopic dermatitis in children, right? If I've had some families who can get access to getting their injectable medicine administered at the school nurse's office, right, every month or something. And then that's great, but a lot of families can't do that, right? And we unfortunately don't sometimes have the bandwidth, or families can't get the coverage, right, to get injections administered, say, at a facility every so often that's convenient for them. And so these are these other types of services that sometimes, we also have to think about, right, when we think about treatments for this disease, and particularly in sort of the pediatric age group.
And thank you for sharing that, because those are some of the unique circumstances that we do have to consider. And as you know, this podcast is geared towards managed care and payer professionals. And in general, the type of work that myself and my colleagues do in that is really managing populations of patients. I think it's one of the big differences between a physician in a payer world, where you're thinking about policies and thinking about the guidelines as well as the cost of various treatments across thousands, if not millions of patients, whereas a clinician, you're focused microscopically on the patient that's in front of you, as well you should be. So there's some differences, and sometimes
Yeah.
those two differences don't necessarily merge. How can we work better as payers and providers to make sure that the policies, guidelines, and the things that we all do work better? What are some words of wisdom there?
Yeah, I think that just as, providers have to kind of stay up to date on, the guidelines, right? Clinical and treatment guidelines for atopic dermatitis. Payers, have to do that as well. And part of it is that, these guidelines for atopic dermatitis in particular, they're always evolving. They're always being updated. And, just as we speak, right, they're being updated by societies such as the American Academy of Dermatology. And I think the American College of Allergy, had just recently issued their most recent guidelines last year. And, as new therapies enter sort of the pipeline for children, and we also obtain more and more long-term data about some of these novel therapies, these guidelines are inevitably going to change. And so I think one sort of thing that both providers and payers have to do is to kind of stay up to date on these guidelines, understand kind of, how treatment indications may be expanding or changing over time, particularly as it relates to pediatric populations. And, as a result of some of these evolving guidelines, any treatment approach to an individual patient, as well as, kind of coverage policies on a more population level, as you mentioned, Dr. Owens, they're going to have to sort of evolve with it as well. And then I think, in terms of just taking a step back and thinking about ways that providers and payers can kind of work together in sort of just kind of this area as a whole, kind of gets back to what we were talking about earlier about kind of the issue of, specialist access and treatment, right? Because that's certainly one area that we know, barriers can still exist. And so, more onerous referral processes can certainly, limit timely access to specialty care. And as we were, talking about earlier, achieving really kind of early disease control rate is more optimal, not just for the patient, but also, more optimal from kind of a disease and comorbidity management standpoint as well, right? We may not need to reach for kind of the more involved and perhaps more expensive therapies if we can kind of see some of these patients earlier in their disease trajectory, right? Be able to kind of manage and achieve control of the disease with sort of easier to access and more cost-effective treatments. And this, also relates to some of the extracutaneous comorbidities that we were talking about earlier, kind of some patients needing kind of additional psychological intervention, right, to address mental health challenges related to their atopic dermatitis, or needing additional evaluations or treatments for some of their, say, allergic comorbidities, such as asthma or allergies. And so again, the earlier that these kind of concerns can be brought to light and appropriately addressed, sometimes in the specialty setting, if it, necessitates that, right, the better the care, I think, in general, that we can provide to patients, and also hopefully the more cost effective the care can be from the payer standpoint too.
And again, thank you for that perspective. And I certainly agree that staying up to date and current on things like guidelines and latest developments, not only in atopic dermatitis, but in all of medicine, is essential. And therein is one of the issues for payers is they need to be up to date on literally every subject that comes along.
Right.
I've often said payers have to be about 2 miles wide and an inch or two deep. So I think we need to lean on folks like yourself and have these educational sessions like we're doing today in this conversation to help payers, because I don't think we can do it alone. I think we have to bring in expertise like yours.
I completely agree. I think, it's a tough job for payers to, as you mentioned, right, have to understand a lot of different disease areas, right, and keep up to date with sort of the evolving treatment landscape, which, across all of medicine, right, we make so many discoveries every day. And so kind of, when you think about sort of the number of therapies that are available for any particular indication, I mean, that has just skyrocketed, right, in recent kind of decades across all disease areas. So it most certainly is a challenge that, I can sort of empathize with from kind of the payer perspective. And I want to also say, like, these forums that you and I have had an opportunity to kind of, chat with each other during, I think hopefully this does provide, a little bit of kind of sort of educational, opportunities for payers to better understand, in our case, right, kind of the scope of atopic dermatitis management. But certainly I'm sure, through series like this, understand a lot of kind of the evolving guidelines for other disease areas as well.
Great. Well, thank you. And as we come down the home stretch here, Last year when we talked, you mentioned how transformative access to good treatments early on, and you've mentioned it again today in the atopic disease process, how transformative that can be for families. And you mentioned again today, it's important to help our patients access the most effective care that they can get. What's your experience been in the last year? How's it gone? Are you gaining more appropriate access? Has it become more complicated? And more particularly, since we're geared at payers, what do you think you would like payers to hear most from you? What's the biggest thing perhaps on your wish list or request?
Yeah, I think that, I guess to answer your first question, which is about kind of how things have gone more recently, I would say that, again, this is sort of just my kind of perception, but I feel like things have generally improved with time. I have found that at least in, some of the insurances that, my patients have, right, that some of the criteria for example, with respect to, previously failed therapies, some of those criteria have been loosened or sometimes even eliminated to be able to get coverage for some of the more novel therapies for my patients with atopic dermatitis in particular. And so I think as a whole that has only continued to improve with time. And I hope that, we'll continue, right, to improve and to sort of, have reduced kind of barriers in the way of being able to tap into certain treatments for specific patients. But that being said, I think that just sort of, again, to take a step back and not focus on just kind of the payer and the provider sort of perspective, I think the process, right, of getting kind of timely access to treatment involves so many different parties. I mean, we think about kind of stakeholders in that process, and it's not just, the provider, the payer, but, the pharmacist, for example, that we might be working with, right, to get access to therapies for patients, the patients and the families themselves. And so I do find that there are still sometimes delays that just come with the logistics of having, multiple kind of people involved in a process such as this. And so, for example, we at our institution work with specialty pharmacists based at our institution who really are tremendously helpful in helping us to navigate, for example, prior authorization process, right, for certain therapies. But, communications have to happen between us and our pharmacists and the patients and families, and then, the pharmacists and the payers, right, and back and forth. And so there's almost a sort of network of communication that has to happen and has to, sort of happen effectively and efficiently for this whole sort of, process to be successful, right, for the patient to ultimately be able to access the therapy that we, have recommended for them. And so I think there are still delays there that can certainly be sort of improved upon. But again, it doesn't come down to just one stakeholder. It's really kind of a systems kind of thing. And then I would say, the major takeaway that I would have, for the audience here with respect to kind of treatment access is kind of getting to what we were saying earlier, which is that, as new treatments become available, especially for, my population of interest, pediatric patients, it's really important to be able to kind of evolve, those criteria that are used for treatment coverage decisions and things along those lines, because, I find that sometimes there's a bit of a delay, right, between, say, a therapy kind of hitting the market and then my being able to kind of access it for some of my patients. And so I think, again, part of that just is probably necessary, right, to have some time to be able to generate data to make some of these more, sort of population level decisions from a payer's perspective. But I think as best as we can to kind of be facile and to evolve kind of quickly as, new therapies also emerge and evolve, I think that's ultimately going to, benefit sort of everyone involved and ultimately the patients and their caregivers too.
And again, thank you for those comments. And I certainly do want to pick up on that. You mentioned that care that we give these patients is changing rapidly, and it sometimes does get hard to keep up. But it doesn't mean we shouldn't keep up, but it makes it more challenging. And as you also pointed out, that it's not only the clinical challenges in keeping up with the clinical developments, but the system challenges. As you pointed out, now it's not just a doctor writing the prescription, patient takes it to a pharmacist, takes it home and takes the medicine. There are now specialty pharmacists involved in the systems. There are other intermediates that all play a critical and growing role. With that, I would now like to open the discussion to our audience for some questions. Dr. Wan, this first question comes in for you. For many of the learners joining this program today, they're tasked with knowing about the latest guidelines and treatment options. We talked about that certainly in the body of the program. And they have to know multiple therapeutic areas. So in a dynamic space like atopic dermatitis, where there are changes all the time. There's even newly approved therapies coming out, including an IL-13 inhibitor approved just within the past week. It certainly can be difficult to keep up. So what are those main points you want to emphasize to managed care and payer professionals to know as it relates to the treatment landscape for pediatric atopic dermatitis?
Yeah, so that's a great question to start us off. I first I want to say I completely empathize with managed care and payer professionals about this because there are so many new therapies for atopic dermatitis that have come out, especially in the last few years, and the pace has just been so rapid that it's sometimes hard even for guidelines to keep pace. So I would say that probably the main point to know is that new therapies are only going to continue to emerge for atopic dermatitis, which does make this treatment landscape just ever evolving. And as a result of this, I think there will be a much greater and increasing need for research that's focused on comparative effectiveness, comparative safety of a lot of these novel therapies, including some of the long-term outcomes that we might expect to see in our pediatric patients. So these data will be highly helpful both for clinicians such as myself, as well as managed care and payer professionals to understand how we should be approaching the utilization of these therapies. But I will also say that all in all, it's a wonderful thing that we have a growing number of available treatments for pediatric atopic dermatitis because it allows us to select the right treatment for the right patient. And we know that atopic dermatitis is a really heterogeneous disease. We know that from clinical trials, any single novel treatment is not going to be effective in every single individual who receives it. So there really can't be one blanket approach to atopic dermatitis therapy, for children with this disease. And so it's really vital for managed care and payer professionals as well to recognize that we need flexibility in some of these policies to allow for patients to access the treatments that would be the most optimal for them.
Yeah, again, that dilemma we have of payers is trying to write policies for the population versus leave enough opening that art of treating these patients that you mentioned earlier can be used as well. So I have another question about specialist access. And from an access perspective, what can payers do to help expedite the referral process? And once a patient gets to see a specialist like yourself, how do you envision the best case scenario for patients starting the treatment in a timely way?
Yeah, so I guess first to address the kind of first part of that question about, just the referral process, I would say anything that can be done to just simplify that process as a whole for everybody kind of involved, right? There's sort of simplification from a prior authorization process on our end as, a specialist's office, making sure that we can actually see a patient in a timely manner. Also simplifying that process for, say, a referring provider, primary care clinician who's directly referring patients to us, giving them the ability to, directly refer and simplifying that process as well. And then I think it's great to have education and resources available for referring providers as well, so that they also can recognize when they really need to refer a child with atopic dermatitis on to specialty care. In response to kind of the second part of that question about, what we can sort of envision as the best case scenario after they've seen a specialist such as myself, I think, again, it sort of comes down to just streamlining processes as much as possible for all involved parties. So, making it easier for us to submit prior authorizations, expediting those prior authorization reviews, really cutting down on approval, turnaround times. Those are all very helpful things that ultimately benefit our ability to provide the best care and hopefully also, the most timely access to therapies for patients. And then in the situations where medication is not approved, making that appeal process more efficient, transparent, and being clear about, reasons for denial so that we can kind of address some of those as well.
No, it all makes sense. And much like you made the comment about payers having to keep up with everything, I certainly sympathize with you having to keep up with all the different payers. It's not just one payer. There are many of us, and we often tend not to do things the same way. The old adage, you see one payer, you see one payer is certainly true. So I think it's a two-way street. We both need to work a little bit better with each other. And our last question, something we heard during the discussion, is there a variety of extracutaneous symptoms in these patients, challenges in social and emotional issues, and they come up with AD. Is there anything you'd want to emphasize to payers around the impact of atopic dermatitis on the social, emotional well-being of children living with moderate to severe disease.
Yeah, so you're absolutely right and it's great to point out that atopic dermatitis has been associated with a growing number of kind of psychosocial concerns, things like anxiety, depression, even ADHD, hyperactivity, and attention. And we also have to recognize that atopic dermatitis is associated with a lot of sleep disturbance, right? Which also can really feed into some of these social emotional concerns. So what I will say is that as clinicians, right, we often are treating our pediatric patients as whole individuals, right? They're not defined by just kind of the objective severity of their atopic dermatitis disease. We also have to account for a lot of the social emotional impact of having atopic dermatitis, a lot of the sleep disturbances that we see in our patients with atopic dermatitis. And that often factors into treatment selection. And so, where that may kind of circle back around to kind of payer professional kind of considerations. Again, sometimes we are selecting treatments because we not only have to treat kind of the objective severity of the skin disease, but also really treat, some of these really major social emotional kind of consequences of having a chronic disease like this. And then, also related to that, being able to help our patients kind of access, non-pharmacologic therapies, right? Psychological support, psychological kind of referral services and things like that, that can also be really important in this patient population as well.
Well, great. Well, it looks like we're running out of time, Dr. Wan, and I want to thank you most sincerely for sharing your thoughts today on how we can improve the quality of care for these pediatric patients with atopic dermatitis. I want to be sure to thank Sanofi and Regeneron Pharmaceuticals for their generous support of this educational activity. And thank you very much and enjoy your day.